up next, we are going to hear about specialty care in SMA with cardiology and pulmonology. And I would like to introduce our two presenters for this session. Dr. Larry Markham is Professor of Pediatrics and Medicine at Indiana University School of Medicine and the Division Chief for Pediatric Cardiology, Riley Hospital for Children at IU Health. Dr. Markham's interests and investigations have been focused in inherited conditions with cardiovascular disease as part of the condition. He was the co-chair of the 2014 National Heart, Lung, and Blood Institute-sponsored working group, which published contemporary cardiac issues in Duchenne muscular dystrophy, and co-authored of the 2017 American Heart Association scientific statement entitled Management of Cardiac Involvement Associated with Neuromuscular Disease. And then second, we will hear from Dr. Sandeep Puranik, who completed his pediatric residency and was a chief resident at Flushing Hospital Medical Center in Queens, New York. His fellowship was in pediatric pulmonology and lung transplantation at UPMC Children's Hospital of Pittsburgh. He is currently the clinical assistant professor of pediatrics at Indiana University School of Medicine and working as attending pediatric pulmonologist with special interest in respiratory management in children with neuromuscular diseases. So Dr. Markham, I will let you go ahead and present your screen.
So it says I can't start my video because it's been disabled by the host.
Okay.
There we go.
All right, I see you. Are you able to share your screen? Perfect.
All right,
Thank you.
can you see that? Does that look
yes,
good?
I can. Yep, it looks great. Thank you.
Okay. Thank you, Nicole and Marcia, for this opportunity. It's always nice to present some thoughts on different conditions, especially for families and individuals with that condition. I have no financial disclosures related to this talk. This is my brief outline. I'll touch on some general care, which was discussed earlier, talk through a little bit about and try to answer the question, is there a concern for heart muscle involvement? And then really outline some things about specific cardiac components, so structural heart disease, or structural malformations, functional heart disease, or cardiomyopathy, and then some thoughts on electrical, particularly the autonomic nervous system. So as I'm sure was discussed, the care of an individual with SMA takes a lot of people, from the patient to the family, care coordination, most prominently the neuromuscular specialist, but also pulmonary, orthopedic, nutrition, as well as acute care for those infections or other concerns that might need an urgent evaluation. And then from the neuromuscular guidelines, you have other organ involvement, which is where cardiology comes in. And so a few general points to consider, and I think this is important for any patient with a chronic or lifelong illness, is that a proactive approach, so whether that be to screen for expected complications of a condition, or to make a diagnosis, or really to manage any cardiovascular complications should there be concern, really being proactive and forward thinking is paramount to having the most optimal outcomes. And the second point really is identifying a cardiologist or a care team members who have expertise in your condition, particularly depending on the condition being evaluated. And so an individual such as myself, and then Dr. Parent, for example, who is a member of our team, we both have expertise in congenital heart disease, which we'll talk through some of the structural malformations, we have a particular interest in neuromuscular disorders. And so we work with our neurologist very closely, actually in the same clinic space. Dr. Parent is a heart failure specialist. So if a patient in one of these conditions develops heart failure, and then also heart rhythm specialist. So really depending on what the problem or the condition has, it's important to put yourself in front of the right person to help manage your particular condition. We have heard about the risk of anesthesia, particularly with regards to respiratory complications. And I also think it's important if you're undergoing anesthesia or other procedures, there is a risk for complications from a cardiac perspective. And so just making sure that your cardiac evaluation has been performed and there are really no additional risk to you from an anesthetic perspective is key to have the best outcomes. And so when we look at the guidelines for the diagnosis and management of SMA, and all the individuals on this call would be familiar with the statement that SMA is a motor neuron condition, and the deficient protein actually is expressed in all cells. And so because of that, there really is an ongoing discussion between basic scientists, clinicians, as well as the pharmaceutical industry and therapies as to really what extent these other tissues might be affected in patients with SMA. And most of the literature really only shows a minority of patients that have clear clinical manifestation of other organ involvement. However, we'll talk through this as we go forward, and it has already been mentioned about the natural history. So if the natural history of a condition is that the majority of individuals die from their condition at a very young age, and therapies are coming along which then change that natural history such that patients are living longer, then there is potential and more opportunity for other tissues to be affected. And so I think that will be something moving forward that the community needs to keep an eye on, is what happens to other systems with patients living longer. And so if you look at this cartoon, it really shows different body systems, and tries to outline that SMA is a multi-organ disease. And the evidence underneath each organ system, for example, in skeletal muscle, there has been significant human data, as well as animal studies showing how the skeletal muscle has been impacted. I will say the information on the heart is somewhat limited in that from a human standpoint, a lot of what is known from a heart standpoint is based on human autopsy studies in those with very severe congenital heart disease. And you can look through all the other systems and see that some organ systems really have not been studied as well as one might imagine. And so it really is unknown to a certain degree how impacted other organ systems are. And so this has been mentioned as well, and I put this up here because I will refer to this classification. But some of the difficulties as a clinician with SMA really includes its wide range of phenotypes, or what people look like in the context of their SMA. And so some of the classification is based on age of onset and then the maximal motor function, which is achieved. And so the severe neonatal form has been labeled as type 0, very weak infants as type 1, non-ambulant patients able to sit independently type 2, and then 3 and 4. And as we said, the natural history is being redefined. And so what these maximal motor function that will be obtained will be modified by therapies. And so when we look at the literature and guidelines and then things that are outlined in the diagnosis and management, there are cases of congenital heart disease or defects, but most of the world's literature, this has really only been shown in severe neonatal onset SMA. And I will talk through a little bit. There's actually a case report of a single family with 2 children who had severe congenital heart disease where they essentially were missing half of their heart. But this is not something that is seen widespread. However, in SMA type 1, there can be some hemodynamically relevant cardiac defects, and we'll talk through what some of those are. Also in SMA1, there has been autonomic dysfunction, which we will also talk through. And then if you look at SMA type 2 and 3, and then even 4, cardiac involvement is much less frequent. But then this gets to some of the other conditions that I see and take care of is if the natural history of a condition is modified, how will that ultimately impact the heart? So muscle contraction benefits the heart, but also puts a stress on the heart. And so it's this question that by improving muscle function and improving ambulation or improving strength, are we having a positive impact on the heart or potentially a negative impact on the heart? And those are questions that aren't completely known at this point in time. I joke around with patients that structural or congenital heart disease is similar to Baskin-Robbins in that there are 31 flavors roughly. I've listed a few here which have been shown to occur in SMA. So some simple congenital heart disease is an isolated bicuspid aortic valve where the aortic valve itself is malformed with only 2 leaflets instead of 3. There are reports of small shunts or holes in the heart or an extra connection, an ASD, which is a hole between the top chambers, a VSD, which is a hole between the bottom chambers, and a PDA is something we are generally all born with that connects the aorta and the pulmonary artery. Some of those, depending on their size, would not need intervention, but some may come to needing intervention. Moderate congenital heart disease includes something like a bicuspid aortic valve, but that also has dysfunction. So a valve that doesn't open very well would be termed a moderate aortic stenosis. And even a complex VSD, for example, could be seen in a patient with tetralogy of Fallot, which has a hole between the 2 pumping chambers, as well as obstruction or narrowing to the pulmonary artery. And then in SMA, as I mentioned, there are some reports of hypoplastic left heart syndrome, which is essentially the small left heart is not compatible with life without intervention. One thing I will bring up is these are congenital heart conditions which individuals are born with. They do not develop after birth. And so if you had one of these, you would know about it with evaluation, and this is often prompted by signs or symptoms, which I find it difficult sometimes to connect symptoms related to a neuromuscular condition and symptoms completely related to congenital heart disease. So some symptoms might be tachypnea or breathing fast, a fast heart rate, poor feeding, sweating with feeds, poor weight gain, altered skin color, altered alertness, all of which could relate from pulmonary insufficiency or skeletal muscle insufficiency as well. When you're looking at a patient, you might see respiratory distress. You might have a murmur, which is what you would hear on auscultation, some cool extremities, or actually a low saturation on pulse oximetry. All of that could prompt an echocardiogram or an ultrasound of the heart to detect structural difficulties. And so, as I mentioned, when we look at structural heart disease, the studies are very small, and probably the largest study investigated 20 patients, and half of them had simple or small holes in the top chamber or bottom chamber. It's interesting, as we mentioned, the case report of a family with 2 children with hypoplastic left heart or severe left ventricular outflow tract obstruction. That actually is more common than actually the general population. And the hypothesis is that SMN1 protein deficiency actually plays a direct role in cardiac development. And because SMA1 and congenital heart disease has really only been reported in a handful of families, it is suggested that the congenital heart disease develops, particularly if there is something else genetic contributing to that patient's condition. When we talk about cardiomyopathy, that really is a kind of a generic term that really means any disease of the heart muscle. And this cartoon on the right of your screen shows a normal heart with 2 chambers on the top, 2 chambers on the bottom. And a dilated cardiomyopathy is a thin wall, which does not squeeze very well. A hypertrophic heart is a very thick heart there in the middle that doesn't relax very well. And then a special form of cardiomyopathy is arrhythmogenic right ventricular dysplasia. And so the thing that we look for and worry most about could potentially be a dilated cardiomyopathy. However, and we'll talk about this on the next slide, it is very uncommon. But heart failure happens when the heart cannot meet the demands of the body. And so you cannot keep up or do what you would want to do. And it's a very complex syndrome of a lot of secondary effects. It doesn't necessarily mean the heart is stopped. And as I mentioned, it usually occurs when heart function is poor. And so it is highly unlikely that SMA patients will develop obvious clinical ECG or echo signs of cardiomyopathy. And so if something does happen, then it certainly warrants investigation and consideration. And it may be a secondary phenomenon. So one example would be an individual comes in and is very ill with pneumonia and sepsis, for example, and they're not doing well. An echocardiogram may be performed, and you may notice evidence of heart muscle weakness, but that may actually be attributed to their pneumonia and sepsis and not so much SMA. So that when the pneumonia and sepsis is treated, one would anticipate that the signs of cardiomyopathy would resolve and regress. The next topic I wanted to talk about is the electrical system. Very similar to cardiomyopathy, there is not a high incidence of heart rhythm abnormalities such as SVT or ventricular tachycardia. However, there have been reported significant derangements in the sympathetic and parasympathetic nervous system. And the way I think of it is parasympathetic is what controls your heart rhythm and rate at night when you sleep, and sympathetic is the fight or flight response that allows you to run or fight. And so if we look on the side of sympathetic nervous system, increased adrenaline would certainly result in increases in heart rate, a more brisk squeeze of the heart, or increased contractility, and peripheral vasoconstriction, which that means your peripheral blood vessels become tight. So during that event, your hands may get cold, and look like you are poorly perfused, but you're actually warm on the inside. The same opposite applies to the parasympathetic nervous system, which results in decreases in heart rate, a slowing or less heart muscle contraction, and peripheral vasodilation, where you're warm and toasty. And so derangements in the autonomic nervous system actually is what would result in someone maybe fainting at the sight of blood, for example, or standing up in front of a choir and giving a presentation. Fortunately, I'm sitting down doing this, so I don't have to worry about that too much. But those are derangements in the autonomic nervous system. It's not that a dangerous or bad heart rhythm causes someone to look the way that they do. It's actually just changes in the innervation and which system is driving. And so there have been reports of a high parasympathetic tone, or some individuals with SMA having a slow heart rate. And there are individuals who have had periods of where they look like they have poor perfusion, where their peripheral blood vessels are constricted and tight. And so that's something to be aware of and know that it can happen. So, as a parent or a patient, what should you watch for or look out for? These are some things that are kind of generic and vague, but you always want to pay attention to how much time spent sleeping or inability to tolerate routine care or activities. As Dr. Puranik will talk about, that can be a sign or symptom of pulmonary weakness. Heart racing, skipping beats, slow heart rate, or anyone who passes out. I try to teach patients to take their pulse or at least have a pulse ox to measure their heart rate. Sometimes heart muscle weakness can be evidenced by feeding intolerance, rapid weight gain, or weight loss. It's certainly important to look out for. A change in someone's respiratory function could be related to the heart, or swelling or puffiness. And so I'll conclude with this, that sort of four main points: that anticipatory and coordinated care is essential. And so being a part of a team of providers who can look after you and really address all of the different issues that come with SMA is important. Congenital heart disease is usually simple if it's present, and it would have been there at birth. So it's not something that if someone found a hole in the heart at age 5, it was always there. Cardiomyopathy or heart muscle weakness is highly unlikely, but as I mentioned, with SMA, survival is now increasing. And so we will have to see, is there a new natural history of cardiomyopathy that starts to show itself as patients get older? And then autonomic dysfunction is possible for individuals with SMA. And so with that, I will conclude and thank everyone for the opportunity to speak.
Thank you very much. Dr. Puranik, you want to go ahead and start your slides?
Yeah.
Can you see my slides?
No. If you hover over the share icon, you would be able to grab your PowerPoint from there.
Yeah. Can
There
you
we
see?
go. Perfect. Thank you.
All right. So thank you for this opportunity. It's really wonderful to talk to families of patients, who care for SMA, and oftentimes we learn a lot from them, and there's always every time when I see them and meet them, I learn a lot. So thank you for this great opportunity. So I'll be briefly talking about the pulmonary care in patients with SMA. Um, so I don't have any financial disclosures to make. So this probably is a slide which I can skip because everybody who spoke earlier have talked about this. But briefly, spinal muscular atrophy, SMA, is an autosomal recessive disorder with an estimated incidence of 1 in 6,000 to 10,000 live births. Newborn screening, fortunately, is becoming available in almost all the states slowly and rest of the world, which is great. As Dr. Markham was mentioning, it is classified into various types based on how severe the muscle involvement is. And we have to remember SMA is a disease of muscle fatigue, and this is particularly important for me to stress because the infants, particularly with type 1 and type 2, they have a lot of muscle fatigue, which needs to be recognized when we are treating them, particularly when they are sick. We also have to remember that respiratory system involvement is universal in patients with type SMA of any type. But the only difference is the degree of involvement is different in different SMA types. More severe the muscle weakness, the more severe the involvement of respiratory system. But the great news is the new therapies are changing the natural history of SMA for good, and these are all very exciting for us. I'll be the happiest to not see these patients with any respiratory problems in the coming future. So aims of this talk are going to be to understand the impact of SMA on the respiratory system, and what are the clinical problems that involves respiratory system in this group of patients. Namely oropharyngeal dysphagia and aspiration, impaired airway clearance and risk for infections. Sleep disorder breathing is another most important one, and skeletal deformation and restrictive lung disease. So I'll be also talking about management of these respiratory issues. Although each of these can be a talk of their own, I'll try my best to summarize so that I give a brief overview of all the issues. So talking about the impact of SMA on respiratory system, we have to understand that we have various muscles that help us breathe, and diaphragm is the predominant muscle of breathing. If I were to say, attribute a percentage of function in terms of breathing, I think diaphragm does almost 90 to 95% of the breathing task, with some support from the intercostal muscles, which kind of form a mesh on our rib cage. So in SMA, it's very important to know that the intercostal muscles are weak, and this makes the diaphragm a relatively stronger muscle. And what's the impact of this disproportionate strength is that the unopposed action of diaphragm on the chest wall results in bell-shaped chest, and sometimes the sternum, the bone in front of our chest has sunk in, and that's called pectus excavatum. What does this do? This results in essentially the pump failure. So when I call pump, it simply means that the group of muscles on top of our chest wall, including the diaphragm, together form what I call a pump. And when this fails because of muscle weakness, the patients typically tend to have difficulty in clearing secretions, difficulty in ventilating, which means eliminating carbon dioxide. As a result, they experience hypoventilation, which is one of the most important things that happen in patients with SMA. They are at risk for infection because they are unable to clear these secretions, particularly when they are sick, and they have increased tendency to have lung collapse because of that. Their cough is weak, so they are not able to clear the secretions really well unless they are supported by assist devices like a cough machine. Also, they have difficulty in swallowing. As a result, they may aspirate some amount of food, particularly liquids, and that can cause lung damage both acutely and as a long term. And we should not forget that salivary secretions are also contributing to this, and they may damage the lungs on a long-term basis. Because of the muscle weakness, the rib cage and the spine, it has increased tendency to get deformed, and that again kind of abnormally stretches the muscle and puts the muscle in a disadvantageous position. And this is how our respiratory system gets involved in patients with SMA. And this is a picture which shows how our patients with SMA, particularly infants with type 1, they have a kind of abnormally shaped chest wall, which we call as a bell-shaped chest wall. So normally when diaphragm is driven down when we inhale, the stability of chest wall is maintained by the opposite action of intercostal muscles. And this normal functioning is lost here because there is unopposed action of diaphragm. And instead of the chest wall staying stable, it is kind of sucked in. And that's the reason why the shape of the chest is kind of bell-shaped, because of unopposed pulling in of the chest wall. So coming to the first aspect of my highlight on how different bodily functions are affected by weak muscles. So oropharyngeal dysphagia and aspiration is one of the most important things that we are worried about in patients with SMA. Believe it or not, we have close to 50 pairs of muscles and nerves that are involved in chewing and safe swallowing. It is a highly coordinated orchestra of events that kind of help us safely chew and swallow and coordinate our breathing when we are swallowing. So you can imagine when patients have SMA, they have a weakness of all these muscles that are involved in safe swallowing, and they are at high risk for aspiration because of that. Sometimes the symptoms are obvious. They present with coughing, choking, difficulty in breathing, taking a long time to complete their feeds, and sometimes they tear up, like we all do when we choke on something. But oftentimes it is silent, which means that they don't have any obvious symptoms. So that's the reason why clinicians should have high index of suspicion for these kind of issues. So we recommend screening for silent aspiration and even oropharyngeal dysphagia or swallow dysfunction. And we use video fluoroscopic swallow studies and barium swallow studies to diagnose this. And this is particularly important for infants who have severe form of disease. Also, gastroesophageal reflux is one of the issues that we often see. Infants particularly, like any other normal baby, they can have reflux, and because of weak muscle, poor cough, poor reflexes, the impact of gastroesophageal reflux and aspiration because of that, which is a retrograde kind of aspiration, can have damaging effects on the lungs. So to overcome this, we typically end up recommending nasogastric tube feeding and gastrostomy tube feeding. As I was mentioning before, chronic salivary aspiration is again an important risk factor on a long-term basis, which can affect lungs, lead to collapse and recurrent infections in infants and children with muscle weakness in general. So one of the other things that happens in infants with SMA or any neuromuscular disease with muscle weakness is impaired airway clearance and infections. As you know, a cough or any mechanical tool that we have as a normal human beings to clear our secretions are weak in patients with neuromuscular diseases, particularly SMA. They have patients have both inspiratory and expiratory muscle weakness, and of course, they have ineffective cough because of that. But they have normal mucociliary clearance, which means that our cilia that we have inside our airways are capable of beating up all the unwanted secretions up to the level of our throat, and we are able to swallow them, and we don't keep count of how many times we swallow in a day. But when children are sick with, say, a respiratory infection, a common cold, they make 3 or 4 times the amount of secretions that we normally make on a routine basis. So there comes the problem, when they have a lot of secretions to clear, the mucociliary clearance by itself is not sufficient, and they need additional help. They try to cough, they cough, but the cough is very ineffective because of the weak muscles. And that's where the ineffective cough leads to retention of respiratory secretions, particularly during infections, as I was mentioning, and leads to infections and airway collapse and complications of pneumonias. Pulse oximeter is a very useful tool which all patients with SMA should have at home, and they should check their pulse oximeter and oxygen saturation when they are sick. Make sure that their oxygen saturation is anywhere between 95 to 100%. Airway clearance therapies are extremely important, and I'll be talking more about them. And mechanical and manual airway clearance therapies and postural drainage, all those are extremely important, which I'll talk a little bit more in detail later. As Dr. Markham was mentioning, yes, sleep disorder breathing is a real problem in anyone who has neuromuscular weakness. We all are floppy when we are sleeping, and you can imagine if someone has a muscle disease which gives them a baseline weakness, the sleep could really affect them. And how does this affect patients with SMA is by multiple ways. We have to remember eliminating carbon dioxide from our body is as important as exchanging oxygen at the blood-lung interface. And that typically happens in our lungs. So if a pump has failed, when I call the pump, the chest wall is not able to move in and out really well. So that leads to retention of carbon dioxide, because for carbon dioxide to get eliminated from our body, our chest wall has to move in and out. It's like pumping out the carbon dioxide from our lungs. So when there is a pump failure, the risk for retaining carbon dioxide, which is a byproduct of our metabolism, goes high. And this risk is particularly higher when we are sleeping, when infants are sleeping, when patients are sleeping. And among many phases of sleep, a REM phase of sleep, when I say REM is rapid eye movement phase of sleep, makes them more vulnerable to have sleep disorder breathing and retention of carbon dioxide. So one needs to have high index of suspicion. We tend to screen these patients for sleep disorder breathing, and certainly sleep studies are essential for diagnosis of these sleep disorder breathing. So we have tools to help them breathe better, and as we all know, bi-level positive airway pressure therapies is recommended for anyone who has sleep disorder breathing and they have a neuromuscular condition. Skeletal deformation and restrictive lung disease is very important. Babies with SMA and children with SMA, older children with SMA, they have bell-shaped chest, as I was mentioning before. They develop kyphosis, scoliosis, and chest wall deformities. Some children, they tend to sleep in one particular position, and that particular area where they are sleeping on tends to get deformed over the period of several years. So orthopedic interventions are extremely important. Both surgical and non-surgical options are extremely important. So when our chest wall is deformed, when our spine is deformed, it again stretches already weak muscle. And when that happens, when an abnormally stretched muscle is put at disadvantage, it has tendency to fatigue easily, and that leads to dyspnea. It's kind of double whammy, because there is underlying lung disease that is causing the intrinsic weakness of the muscles, and now there is skeletal deformity because of that, and which again abnormally stretches the muscle and kind of makes it more weak. So it is a vicious cycle, unfortunately, patients, particularly who have severe disease, get into, and we need orthopedic intervention to help them out. So this is a kind of summary of natural history, which is again, fortunately, changing, getting better, and we may not discuss these issues at all 10 years from now, and I strongly hope that that is the case with all the kind of medications that we are you know, having as our options to treat these patients. When it comes to natural history, this is a natural history which I think I touched upon almost all of these, and they're all interlinked. As you can see, it forms a mesh here, and finally it leads to kind of ventilatory failure. So respiratory causes become a prime cause of morbidity and mortality in patients with SMA. So assessment is extremely important, and we have an excellent team here at Riley Children's Hospital where we together see these patients and follow them up every 3 to 6 months, depending on how severe their involvement is, and intervene at the right time and help them out. So what do I mean by respiratory assessment? So for practical purposes, I tend to see them as sitters, non-sitters, and based on what they're capable of, we very fast. Of course, we have clinical tools. We measure the pulse oximeter, we measure the capnography, that is measuring the end-tidal carbon dioxide or transcutaneous carbon dioxide. These give us a kind of information, indirect information as to what is happening at the deeper level inside our lungs. Is the oxygen exchange, carbon dioxide being eliminated properly? So one needs to have very high index of suspicion for sleep disorder breathing in these patients. They may not have clear-cut signs. They may not tell you that I'm having headache early in the morning, or I'm having a lot of fatigue during the daytime, because these are infants and often they cannot talk, and these signs are very subtle. As Dr. Markham was mentioning, they tend to sleep a lot during the daytime. But is this just an infant being infant, taking multiple naps, or is it a sleep disorder breathing that is contributing? Becomes extremely difficult to clinically differentiate. So I think at least I use a lot of sleep studies here and make sure that they are not retaining carbon dioxide, make sure that they are not having any kind of sleep disorder breathing. And I see every non-sitter every 3 months so that I don't miss anything, any subtle signs of the respiratory system involvement. Again, assessment in sitters and walkers, I've clubbed together here for saving some time. But essentially, thorough physical examination is a must for all these patients. And I tend to see them every 6 months. And whenever I see any issue, for example, if they have swallow dysfunction, if they have sleep disorder breathing, if they have signs and symptoms suggestive of poor airway clearance, I intervene with appropriate therapies. So how do I recommend caring for these patients? Again, maintaining high index of suspicion for any kind of respiratory involvement is extremely important, because oftentimes the clinical symptoms are subtle, signs are very subtle. So I always maintain a high index of suspicion. If a patient is capable, then we end up measuring MIP, MEP, cough, peak flow, and all those sophisticated tests that we have. But oftentimes, if the baby or an infant is incapable of doing this because of the weakness itself, then I just rely on my clinical examination findings and the other simple tests that I was mentioning. I invariably measure carbon dioxide levels and oxygen levels, and I often get sleep studies at least as a screening as soon as I see them for the first time, and then yearly, depending on their symptoms. Of course, I look at how the chest wall is behaving. Should I involve orthopedic surgeons? Should I involve other specialists, physical medicine, rehabilitation folks who can help us with braces and all kinds of equipment that we have to help them kind of slow down the progression of the skeletal deformity that we often see in these patients. Airway clearance therapies, this probably is the most important slide of my talk, because if we take care of airway clearance, I think we can keep these patients out of the hospital for a very long time. So I would like to stress the importance of manual chest physiotherapy, combined with mechanical insufflation, exsufflation, which is otherwise called cough assist or cough machine. It has to be the primary mode of airway clearance therapies for all these patients, because they know how to cough. They cough, but unfortunately their coughs are ineffective. So having an ineffective cough is essentially having no cough. And this may not be a huge issue at a routine basis, because our mucociliary clearance can beat all the normal secretions up, but it becomes extremely important to use these machines when they are sick. So again, there is a hate-love relationship with these machines. Nobody likes it when you put a mask on somebody's face and push air through their airway. So I tend to start these therapies very early so that the patients get used to this. And there is, of course, a particular pressure that is considered as effective. Anything between 30 to 40 centimeters of water is great. But I go up, and that is the recommendation, to go up and give them the highest tolerated pressure. Oral suctioning is extremely important, because they oftentimes, the cough machine can bring all the secretions up to the level of throat, but they are not able to spit out or swallow properly, as I was mentioning earlier. So suctioning them with the help of a mechanical suction is extremely important to clear these secretions out of their airway. So this is how a cough assist machine looks like. Needless to say, I'm sure all of the patient parents have seen these, used these, but I just put these out here. And this is the chest vest that we often tend to use in patients with SMA. So what are the special considerations? What are the medications that we need to use? If you go by the latest consensus guidelines that was published in the past couple of years, there's no need for using any other medications on a chronic basis, on a long-term basis. Of course, if someone has asthma on top of that, certainly go ahead and use the albuterol and asthma medications. But using hypertonic saline, pulmozyme, that is the medication that breaks out all the thickened secretions, or using hypertonic saline like 3% saline and 7% saline is not recommended, because it tends to make secretions extremely thin and increase the kind of secretion burden. As I was mentioning, oral secretions of saliva is a real problem. We use medications like glycopyrrolate, which can help thicken these secretions and help them manage it better. But again, this is a very tricky medication, and we need to be extremely careful in using this, because it can really thicken the airway secretions and cause mucus plugs, which can lead to acute decompensation and failure. Of course, we mentioned about vaccines. They are the must. RSV vaccine, the palivizumab, is extremely important, and all babies with SMA should get it. If we identify any gastroesophageal reflux, we need to treat it appropriately and involve our friends from GI. This is extremely important. When someone has signs and symptoms suggestive of hypoventilation, which means that if they are not eliminating carbon dioxide, non-invasive positive pressure ventilation, often BiPAP, that what we call, is extremely useful. And it's very important to use BiPAP and not just supplemental oxygen or CPAP, because that doesn't help like BiPAP in palliating dyspnea and fatigue. Oftentimes we end up giving them two interfaces. One is the nasal interface, and the other one is the full face interface. We do this because to avoid any pressure-related skin breakdown on the face. And it's always recommended that they see a specialist who are capable of and have experience in fitting these masks. And our sleep lab is excellent. And Dr. Rao, who is again one of our a member of our team, is really good at fixing these masks on the infants and young children. So we end up doing clinical titration. As I said, our sleep lab is probably one of the biggest in the country, and we have all the specialists here who take care of that. But if in case if you're in a remote area and there are no sleep labs, certainly doctors can use clinical ways to figure out what are the exact pressures that need to be used for the titration. So this is a mask. Now we have beautiful masks that are coming out, and they are now able to fit it on the smallest of the small babies. I just hope that this gets better and better. So acute illness management is extremely important. I think I have running out of time, but I'll just try to compensate. So yeah, when someone is sick, of course, we have to measure their oxygen saturation, measure their heart rate, and look at their chest wall. And we should have a anticipatory guidance for parents, and they should know what to look for and when to call us. Maintaining good ventilation, nutrition, hydration, and keeping a low threshold to give antibiotics is extremely important. And anticipatory guidance is extremely important and helpful. The training of parents with equipment, because of all these gadgets that we are using, it's extremely important that the parents know how to use these equipment. It can be learning how to use airway clearance equipment, mechanical insufflator, exsufflator, BiPAP machine, the cough, oxygen delivery equipment, and if they need mechanical ventilator, that is again a part of training as well. And we have excellent team here who train our families in using all these equipments here. We mandate that at least one caregiver is ready to actually give full-time care and knows how to use all these equipments. So tracheostomy is again my last resort. I never recommend tracheostomy as a first, so easily. My choice is always non-invasive ventilation, and that's what is recommended, and most of the centers in this country do. But there are patients who end up needing tracheostomy because of chronic respiratory failure and failure of all the non-invasive ventilation, and sometimes complications of non-invasive ventilation. So it's generally indicated for chronic ventilation purposes. If someone is requiring 24-hour BiPAP and they've done non-invasive ventilation for years and now they are developing complications, then that is an indication for tracheostomy. If they have upper airway problems and if there is a blockage there, then certainly we need to bypass that, and that is an indication. If they have difficulty clearing secretions and that becomes a problem, then certainly tracheostomy. If they are acutely ill, admitted in the ICU, and they have difficulty extubating even after multiple attempts, after optimization, that is an indication. So, but again, I believe in having these discussions as an outpatient and kind of prepare families for what would happen if baby is sick in the ICU and we have this scenario situation where we need to consider tracheostomy. At least the family should give it a thought and be prepared with some kind of plan for such a situation. So these are my references for this talk, and I thank you all for this opportunity, and special thanks to all my patients and their parents. You guys are incredible, and I learn a lot from you all. Thank you very much.
Thank you very much, both of you guys. We do have a couple questions that have come in. Dr. Markham, are there any vitamins a patient can take that would help supplement the heart and organs while taking the SMA medications?
So most patients, the recommendation is really to follow a balanced diet. A lot of patients may take a multivitamin, particularly if they have been shown to have a nutritional deficit, such as iron or calcium, and there are some just regular vitamins that can be deficient if you're not taking a balanced diet. Most recommendations would say to avoid these mega doses of vitamins. However, there's one, carnitine is a muscle supplement, and I think if there is concern it's unlikely that you'll see a dramatic impact, or I took this and now I feel drastically different. Some patients who have a lot of autonomic dysfunction, they may be instructed to hydrate or have some type of sodium under the direction of their physician. Sometimes Pedialyte may be used to sort of keep the blood volume full.
Okay. Okay. And a question for you, Dr. Puranik. What are signs that a patient needs adjustments in their ventilator settings? Is it weight gain or sleeping more?
We usually use the sleep lab and the sleep studies to titrate the amount of pressure the patient is getting. We usually tend to maintain a delta P, what we call as difference between the inspiratory pressure and the expiratory pressure of at least 10. And we look for the download data. Every 3 months, we download the data from the machine of these, the BiPAP machines, and we look at the amount of pressure that is being given and the kind of respiratory rate the patient is having. If the patient is clearly uncomfortable, meaning they have tremendous amount of respiratory pressure on top of whatever is the backup rate, then that is a sign that the patient probably needs a little bit more support, and then we call them for a titration study and adjust their BiPAP machine. So yes, it's a sophisticated thing. If clearly the patient is uncomfortable on the BiPAP settings, clearly there is something wrong, and that's when we troubleshoot a few things.
Okay. We have a person that made a comment that they use the vest morning and night during the winter months for preventative maintenance. Do you recommend using cough assist as well, or anything else?
Yes, I would prefer the usage of cough assist on a daily basis. At least 20 coughs in the morning, 20 coughs at night.
For everyone?
For everybody, yes, on a routine basis, because that is extremely important. It's in fact more important than the vest itself, because vest doesn't typically help bring all the secretions from the lower part of the chest. It just shakes it up. But what brings them out is the cough machine. So cough machine is extremely important to be used on a daily basis. At least 15 to 20 coughs in the morning, 15 to 20 coughs at night on a day-to-day basis. And the second important thing that is important for the families to know is when you put pressure on with the help of a cough machine, it actually stretches the muscle and opens up the part of those lungs which have increased tendency to collapse. And increased collapsibility is a very well-known thing in patients with SMA, and it's extremely important to keep the lungs open. And using cough machine and not the vest actually is what keeps those lungs open. And in fact, there is another advantage is when you put the pressure on, hyperventilation that we cause, in fact, can slow down the deformity that is typically seen in patients with SMA, chest wall deformity. So there are several advantages of using cough machine. I'm not saying one should not use vest, but I think if I were to pick and choose one most important, that would be the cough machine for airway clearance. Yeah.
And we have a comment.
And Nicole, this is Arpita. I'll add to it. Our pulmonologist also recommends cough assist for prevention.
Okay, that's good to know. Thank you, Dr. Lukoya. We just have a comment, and I think you both can actually speak to it, but the comment is almost 20 years ago, there was ongoing chatter in the SMA community about long-term ventilation support caused heart issues. There were even debates that patients needed BiPAP vent support would only live 10 years. The community as a whole has proven that wrong, but the concern for heart-related changes due to mechanical breathing support remains. This attendee would just kind of like to know your comments on that situation.
Yeah, so I'll start and then let Sandeep kind of take over a little bit. But so the heart and lungs are certainly connected, and they have a very interesting relationship. And so if you have hypoventilation and high carbon dioxide, that actually increases the pressure inside your lung arteries, which then means that your right pumping chamber has to pump against more pressure than it was designed to do. So someone with respiratory weakness that is actually inadequately treated, they may actually have right heart failure because their lung pressures are high and their right pumping chamber is having to pump against it. And so I think that's where getting the pulmonary support correct is most important. That's one of the reasons that an echocardiogram could be used to actually look at the right heart and make sure that it was at a low pressure, and that's a confirmation that the pulmonary support is actually adequate for that patient. And so while we don't think there is a high chance of left heart weakness, that would be probably the most significant thing that would stand out to me from that question and that debate over years.
Okay.
I certainly agree with that, because as Dr. Markham mentioned, heart and lung is essentially one unit, and they are doing the same. Their main goal is to deliver oxygen and blood to different parts of the body. So if one fails, the other fails as well. It's just a matter of time. So if you keep the lungs in good shape, if you keep them healthy, and if you keep them well ventilated, I think that is going to benefit the heart. So they are unseparable units, I would say, and one takes care of the other, and if one goes wrong, the other suffers as well.
Okay. All right. Well, thank you both very much. I appreciate your time this Saturday.
There is one comment which which is made here in the question and answer section, and I strongly agree with that. Everybody, all patients, particularly the young infants who have severe phenotype and they are seen by a doctor, I think they have to get at least the pulse oximeter and the suction apparatus prescribed on the very first day when someone like that is seen in the pulmonary clinic, and that's a must. And there is no debate in that, because when someone has severe muscle weakness and ineffective cough, there's no way you can get rid of those secretions without a suction apparatus. So it's a must, and there should not be any debate in that.
Okay. All right. Well, thank you very much. I appreciate your time. Thanks again.
Thank you, Nicole.
Thank you.